In this presentation, we are going to be talking about demyelinating diseases. This is a broad spectrum of um, diseases that includes mainly multiple sclerosis, also optic neuromyelitis, and acute disseminated encephalitis. We're going to be talking about each of these diseases separately, but also we're going to see the main differences to that can help us in the differential diagnosis. Multiple sclerosis is a disease characterized by recurring inflammatory attacks to the central nervous system. This includes, of course, the encephalus and the spinal cord, and these lesions are due to an autoimmune etiology. We can see initial demyelinating lesions that leads to reversible acute clinical manifestations known as flares or attacks. Eventually, as the disease progresses, we can see neuronal death and axonal damage that cause permanent and progressive neurological deficits, meaning that eventually multiple sclerosis leads to discapacitation. Now, talking about epidemiology and risk factors, multiple sclerosis tends to affect women more. There is a tendency of 2 to 3 times more affections in women than men. The mean age of onset is usually between 20 to 40 years, and we can see a peak at 35 years. In the case of primary progressive multiple sclerosis, this is different. We can see the mean age of onset is usually later, and later than 60 years, and women and men are affected equally. Um, Also, this disease is uncommon in equatorial climates. There is less incidence and prevalence in temperate climates and cold climates. Also, the rain it's uh, it's a protective factor, sort of say. Our prevalence increases with distance from the equator, meaning that higher latitudes tend to have less cases. This is due to lower sun exposure and consequently lower UV rays exposure. This uh, traduces to lower vitamin D levels, which can be a risk factor to this disease. This is seen in multiple studies where people with the disease as such, meaning with a clinical diagnosis, uh, tend to have lower vitamin D levels than the average population. Talking about the prevalence, the higher prevalence in higher latitudes, we can see in this map, Canada and the United States. We can see have also Groenlandia have more cases, around 20 120 to 300 per 100,000 people. And when we look other countries that are with more lower latitudes, we can see this prevalence diminishes. The etiology of multiple sclerosis is multifactorial. This means that there is a genetic predisposition and an external insult that causes the progression of disease. These genetic predispositions is seen mainly in polymorphisms in principally HLA-DRB 1501, but there is also an association with HLA-A0201 and HLA-DR13. This is the genomic allelic variants. The external insult is also, there's a broad spectrum, but there are three principal. There is an association with viral infections, principally Epstein-Barr virus, also herpes simple virus type 6, measles, varicella zoster, and many others. But the most important is Epstein-Barr virus. Also, there is an association with long-term smoking. There is a hint of possible the lungs being a possible site of activation of these pathogenic T lymphocytes that leads to the disease. Also, as we mentioned earlier, low vitamin D levels are associated with multiple sclerosis. These are the environmental factors. Also, the epigenetic, postgenomic, and regulatory events have a say in this disease. When these three components combine, we can see the phenotypic expression of this disease. The physiopathology of multiple sclerosis is the hyperactivation and erroneous activation of lymphocytes as seen in other autoimmune diseases. There is an erroneous lymphocyte activation. First, there is a dendritic cell that uh, exposes the lymphocyte to the antigen being the myelin. Then this lymphocyte activates and crosses the disrupted blood-brain barrier. This is this can happen because the lymphocyte expresses a series of proteins uh, like integrin and activins that permits the lymphocytes reaches the central nervous system. When it's inside of the central nervous system, this activated lymphocyte um, secretes mainly interferon alpha, the TNF beta, and IL-17. These cytokines cause the activation and expansion of the lymphocyte population, and there is a marked influx of neutrophils, eosinophils, macrophages, and more lymphocytes to the central nervous system. Here, these cells, well, they do what they're intended to do, meaning CD8 positive cells kill neuronal cells and expose axons. They attack the oligodendrocytes and demyelinate the axons. B cells differentiate into antibody secreting plasma cells that secrete these autoantibodies that have all the main effects of the antibodies, complement activation, opsonization, etc. And CD4 cells differentiate into Th1 anti-inflammatory cells, Th2 pro-inflammatory cells, and Th17 pro-inflammatory cells. These cells tend to secrete more and more cytokines that expand the process. Multiple sclerosis tends to have various forms of presentation. There is relapsing remitting multiple sclerosis. This present in 80 to 85% of patients and is characterized by acute or subacute flares or attacks. There is gradual recovery after the resolution of these attacks, meaning there is no neurological deficit, a permanent neurological deficit. There is also a period of recovery of this function, and these periods are known as remissions. Secondary progressive multiple sclerosis presents in more than half of relapsing remitting cases. This progression tends to happen in a mean of 15 to 20 years and is characterized by insidiously progressive neurological impairment with a history of flares. These patients eventually tend to stop experiencing attacks. They usually have less than one attack per year. In this graph, we can see what we just talked about. There is a preclinical stage when there are only MRI lesions identifiable, but there are no clinical symptoms. When we start to see attacks or flares is when we can diagnose multiple sclerosis as such. There are attacks, then remissions, and these periods of recovery, then more attacks, remissions, attacks, and remissions. These remissions gradually tend to cause a deficit, a neurological deficit. We can see this is normal and then tends to get worse. Then in secondary progressive multiple sclerosis is when the attacks tend to happen less often and the disease, the neurological impairment, progresses through time, and then these flares stop happening. There is a primary progressive multiple sclerosis form of presentation. This happens in 15 to 20% of patients. Most patients tend to be older than the previous cases, than most cases. They are older than 40 years. Also, this form of presentation is equally distributed in men and women. There is no more affection of a woman. This is characterized like progressive form from onset without relapses or remissions. There can be pseudo attacks, but they are less than 24 hours. They're short and cannot be named flares as such. There is also the characteristic of ambulatory disability tends to develop 50% faster than relapsing remitting, meaning there is the neurological deficits tend to be more faster. The last form of presentation is clinical isolated syndrome. Uh, this means the first demyelinating event, meaning there is an event, a demyelinating event is the first presentation of multiple sclerosis, but we have not yet seen more attacks that can um, diagnose the disease as such. There are suggestive multiple sclerosis lesions seen on MRI, and there is a high risk of developing multiple sclerosis in the next 2 years. But the syndrome alone is not multiple sclerosis. It's like the previous of multiple sclerosis. This divides in low risk or high risk clinical isolated syndrome. And the difference between these two is in low risk there is a lesion in an MRI different topographically than the symptoms, but in high risk clinical isolated syndrome there are multiple lesions in an MRI topographically where the symptoms are uh, expected to originate from, but there are also lesions in other places. Also, there is in the SEC analysis, we can see oligoclonal bands. Now, the clinical findings of multiple sclerosis is highly variable. In this table, we can see the most common symptoms being this. This tend to happen in more than a third of patients, but is highly variable. The most common symptom is weakness. There is limb weakness, also loss of dexterity or gait disturbance. There is fatigue after exertion is common. Also, we can see a presentation of upper motor neuron syndrome with positive Babinski reflex, spasticity, and hyperreflexia. The second most common symptom is sensory disturbance. This is seen as paresthesias, dysesthesias, or hyposthesias. There is commonly unilateral numbness in one leg that spreads to the other leg and then ascends to the abdomen. This tends to be the clinical presentation, the most common clinical presentation of sensory disturbance. Also, Lermite sign usually is present, and this tells us about spinal cord involvement, and this sign is a sensation of in the back when there is a flexion of the neck. There is an electrical sensation in the back. The third most common syndrome seen in multiple sclerosis is optic neuritis. This is characterized by an hyperacute, unilateral, partial or complete loss of vision. The patient refers this blurriness in the central field of view that is named scotoma. There is also color desaturation, mainly in red, but it can also happen in green colors, and periorbital pain during a movement, principally a horizontal movement. We can also see ataxia and tremor. This is due to affection demyelinating lesions in the afferent and efferent cerebellar pathways. Uh, this is we can see this in the finger nose test that tell us there is dysmetria, also dysodocosinesia and positive Romberg sign. We can see also the tremor can be variable from intention tremor to severe disabling tremor. Diplopia presents in about half of patients with multiple sclerosis, and this is referred by the patient as blurred vision. We can differentiate blurred visions from optic neuritis and disconjugated eye movement by covering one eye. When it's due to optic neuritis, this does not resolve the blurred vision, but when it's caused by disconjugated eye movements, this resolves the blurred vision. This is due to internuclear ophthalmoplegia, meaning there is a lesion on the medial longitudinal fascicle that connects the tear nucleus of the nucleus of the tear cranial nerve and the sixth cranial nerve. This causes the disconjugated movement of the muscles, and we in the physical examination, this is the the manifestations we see in the patients when we ask them to look to the right, to the center, to the left, or across their eyes. When it's bilateral, we always think of multiple sclerosis because this is the main cause. Also, vertigo and fatigue is common. Mainly fatigue is a very common symptom of multiple sclerosis. The patient refers he feels tired all the time or in periods. Also, facial pain is another syndrome we can see in multiple sclerosis. This is due to trigeminal neuralgia, and these present as paroxysms of lancinating severe pain. We can make a differential diagnosis with idiopathic or trigeminal neuralgia because in multiple sclerosis tends to be bilateral. There is a constant duration and usually involves the first branch, and we can see sensory loss in the physical exam. But the first branch involvement tell us there is a high possibility of multiple sclerosis. Other less common symptoms, but highly suggestive symptoms that you can find in multiple sclerosis patients is bladder and bowel dysfunction. The patient refers urinary urgency, frequency, hesitancy, and incontinence, also nocturia. There is facial weakness, flexor spasms. These are also common, and this is presented with paroxysmal tonic spasms of a limb or face, preceded by a paresthesia. This is the presentation, the common presentation. There is also cognitive impairment. This is believed to be in the late stages of the disease, but also in the earlier stages of the disease, this can happen, and this is presented with short-term memory deficit, attention deficit, deficit in problem solving, and language dysfunction. Dysarthria is also a disease, a symptom we can see in multiple sclerosis patients, and this can be caused by tongue weakness, spastic dysarthria, involvement because there is involvement of the brainstem, or scanning dysarthria uh, by involvement of the cerebral cortical lesions. Also, there is dysphagia and facial myoclomia. For the diagnosis of multiple sclerosis depends of the form of presentation of the disease. Uh, Two or more relapses or attacks with an objective clinical evidence of two or more lesions, meaning there are two or more syndromes present. This can be motor disturbances, sensory disturbances, or optic neuritics, for example. There is no non-additional data required for the diagnosis. When there are two or more relapses with objective evidence of one lesion, but clear historical evidence of a previous attack involving a lesion in a distinct location, there is no additional data needed for the diagnosis. When there are two or more relapses, but there is only one syndrome that evidences one lesion, we need dissemination in space. This is demonstrated by an additional attack involving a different uh, location in the central nervous system, or meaning another syndrome, or an MRI, typical lesions. When there is only one relapse with objective clinical evidence of two or more lesions, meaning this one attack, we saw two or more syndromes, optic neuritis or myelitis transversa, for example. We need dissemination in time. This is demonstrated by a second clinical relapse, MRI lesions, or presence of cephalorhynchus specific oligoclonal bands. When there is one relapse, objective clinical evidence of one lesion, we need both dissemination in space and dissemination in time, demonstrated by a second clinical relapse or MRI typical lesions, or SECF specific oligoclonal bands. When there is an insidious neurological progression of suggesting multiple sclerosis syndrome, we need 1 year disease progression and two of the following, meaning we need retrospectively or prospectively follow this patient, and we need a positive brain MRI with these characteristic lesions, and also lesions with positive uh, visual evoked potential, positive SECF, positive spinal cord MRI lesions. In general, the diagnostic of multiple sclerosis, we need the clinical events. We need to characterize it in frequency, duration, and time of onset, and we need the additional studies, mainly MRI, but also as CSF analysis. The diagnostic studies that can help us in the diagnosis of MS is mainly MRI. There are characteristic lesions seen on T2 and fly MRI, and these are multiple areas of hyperintensities. These are round or ovoid in appearance, and the localization of the lesion is periventricular, cortical or juxtacortical white matter, infratentorial in the brainstem, or the spinal cord, also subcortical and localization. In T1, we can see areas of hypointensity in the same areas previously mentioned, and these are known as T1 black holes. These are the diagnostic criteria for dissemination in space and in time for MS. Dissemination in space meaning there are multiple lesions in various locations. In dissemination in time meaning there are uh, there are lesions that progressively expand to another areas. This image shows the characteristical lesions of MS. In T1, we can see the hypointensities. These are multiple juxtacortical in this case and are known as black holes. This is periventricular, this is juxtacortical. In T2, we can see hyperintensities, and while the localizations are variable, we can see multiple lesions, rounded, and well, in this case, these are periventricular, where also there is subcortical. Other diagnostic studies that can help us is SECF analysis. We can expect elevated total IgG synthesis, IgG ratio, and total IgG is elevated also. There is presence of 2 or more oligoclonal bands that are not present in a simultaneous serum sample. This is the oligoclonal bands that we see in MS. Also, another study that can help us is about potentials. When imaging, these are used when imaging studies or physical findings do not support the clinical impression, and the typical finding is asymmetric delay of the P100 potential and conduction block. This is a normal visual evoked potential, and this is an abnormal MS evoked potential. Other important demyelinating disease and a possible differential diagnosis for MS is neuromyelitis optica spectrum disorder. This was previously thought to be a subtype of MS, but now is seen as a different disease. This is an aggressive inflammatory disorder characterized by recurrent attacks of optic neuritis and myelitis. This can be monophasic, but is typically multiphasic. There are multiple layers of disease. 40% of patients tend to have a systemic autoimmune disorder. This is principally LS, Sjögren, and Hashimoto. These are the most associated. Onset is associated with varicella zoster virus, Epstein-Barr virus, HIV, or TB, tuberculosis infection, meaning this causes the progression of disease. And neuromyelitis optica is associated with a highly specific autoantibody against aquaporin 4 channels, and these are known as NMO IgG autoantibodies. These aquaporin 4 channels are localized in specific parts of the brain, and these regions are the most affected by this disorder. The core clinical syndromes that presents with neuromyelitis optica is optic neuritis principally. This is present in 75% of patients. It's mainly unilateral, but when it's bilateral, it's highly suggestive of this disease. It's usually severe, differentiating from MS, that is uh, is less severe. There is also complete loss of vision in up to 44% of patients. Acute myelitis tends to be bilateral, symmetric. It can be sensitive and or motor impairment, but also it can be just one of them. It usually presents as tetraplegia or paraplegia, and there is a positive Lermite sign previously mentioned. Also, another syndrome we can expect is an area post-trauma syndrome. This is characterized by episodes of otherwise unexplained hiccups, nausea, or vomiting that usually are intractable. Also, we can see acute brainstem syndromes, symptomatic narcolepsy, and symptomatic cerebral syndromes. These are the diagnostic criteria for neuromyelitis optica. And these are based in the presence or absence of the aquaporin 4 IgG autoantibodies. When we have them, the criteria are these. We need at least one core clinical characteristic that we previously mentioned. These are the core clinical characteristics. Um, we need a positive test for autoantibodies and an exclusion of alternative diagnosis. When we don't have the NMO IgG autoantibodies, or we don't know if are present, we need at least two core clinical characteristics occurring as a result of one or more clinical attacks. And they need to meet all of the following requirements. At least one core clinical characteristic must be optic neuritis, acute myelitis, or area post-trauma syndrome. The three most important. We need dissemination in space and fulfillment of MRI requiremements. The negative test of aquaporin 4 channels, autoantibody, or the testing is unavailable. The MRI requirements are this listed in this table. And in acute optic neuritis, we require brain MRI showing normal findings or only non-specific white matter lesions to make the differential diagnosis with MS. We need optic nerve MRI with hyperintense lesions. In acute myelitis, we require intramedullary lesions extending more than 3, this is highly specific of this disease, contiguous segments, or more than 3 contiguous segments of focal spinal cord atrophy. And in area post-trauma syndrome, we require lesions in the area post-trauma. In acute brainstem syndrome, we require brainstem lesions. What we expect to find in the diagnostic studies, first in MRI, is longitudinal, meaning is in multiple segments. Extensive, meaning there is involvement of all the tracts in the spinal cord. Lesions involving 3 or more contiguous vertebral segments seen on T2 weighted MRI. Brain MRI usually is normal, or there are non-specific lesions. There are no typical lesions of MS. There are lesions rarely seen on T1. Lesions on FLAIR are typically less than 3 millimeters. And the localizations of the spinal cord lesion are usually central. And in MS, these are peripheric. In CSF analysis, there is marked pleocytosis with neutrophils and eosinophils present. Also, oligoclonal bands are uncommon, and only 30% of cases are present, and this disappears during active disease. While in MS, the oligoclonal bands are present throughout all the progression of the disease. In these images, we can see the typical lesions of neuromyelitis optica. There are involvement of more than 3 segments. Also here, there are hyperintensities involving multiple segments. There is lesions of the optic nerve. This is a normal optic nerve, and the upper image is an affected optic nerve with hyperintensive lesions. In this, we can see hyperintensive lesions in the area postrema that can cause the area postrema syndrome. Acute disseminated encephalitis is another demyelinating disease. This has certain characteristics that can differentiate it from the previous diseases. This is monophasic, and this is characterized by multifocal inflammation and demyelination. Is more common in children, while the other diseases are more common in adolescence and adulthood. Is associated with recent rabies or smallpox vaccination, and this is known as post-vaccination encephalomyelitis. Also, with recent infection of measles, varicella, mononucleosis, influenza parainfluenza, rubella, and mycoplasma pneumonia, and this is known as post-infection encephalomyelitis. The pathogenesis is molecular mimicry with cross immunity with the central nervous system. The most common clinical findings is there is an antecedent of vaccination or infection with the previous viruses. There is a rapid onset of multifocal symptomatic involvement of the cerebrum, brainstem, cerebellum, and spinal cord. This can be simultaneous or can happen in succession. Alterations in consciousness and seizures are common, and also another presentation is heart disease. This is an acute hemorrhagic leukoencephalopathy due to microvascular hemorrhagic lesions, and this is presented with a progressive rapid disease with seizures, focal neurological symptoms, and progression to coma. So this is the presenting symptoms of acute disseminated encephalopathy. Fever, weakness, cranial nerve palsy with involvement of the brainstem, nausea and vomiting, meningeal signs, ataxia, and seizures. This figure helps us to make a differential diagnosis with an acute attack of multiple sclerosis and acute disseminated encephalomyelitis. There is an antecedent events of infection and vaccination. Clinical findings are in multiple sclerosis focal, and in the acute disseminated encephalomyelitis tends to be well disseminated. There is meningismus and stupor and focal signs. The course is monophasic. There is only one attack. The MRI features tend to be diffuse, bilateral, symmetrical lesions, and the prognosis is a rapid recovery, often complete. Multiple sclerosis tends to be progressive and uh, incapacitating. Finally, the diagnostic studies that can help us make the diagnosis of acute disseminated encephalomyelitis is CSF analysis. You can see marked lymphocytic plasitosis. There is marked protein elevation and signs of intrathecal synthesis of gamma globulin. In the brain MRI, we can see multiple areas of abnormal signal chain, often contrast enhancing, meaning this is an acute lesion, and there is usually perilesional edema. We can see in these images the dissemination and the multiple lesions in the encephalus, also the involvement of the optic nerve, and well, this is highly specific of this disease.